A term 41-week newborn presents with respiratory distress and severe hypoxia shortly after delivery. I'm showing you the chest radiograph. Describe the findings.
All right, let's take a look. The chest radiograph demonstrates bilateral diffuse, patchy, and coarse opacities in both lungs, representing areas of atelectasis and consolidation. The lung volumes appear mildly hyperinflated, and there are small bilateral pleural effusions. An endotracheal tube is positioned just above the carina, and a nasogastric tube passes into the stomach. No pneumothorax or pneumomediastinum is seen. These findings in a term infant are typical of meconium aspiration syndrome.
What is the pathophysiology of meconium aspiration syndrome, and what are its potential air leak complications?
Meconium aspiration syndrome occurs when intrauterine stress or perinatal hypoxia triggers gasping and passage of meconium-stained amniotic fluid into the fetal airways. The aspirated meconium causes mechanical airway obstruction, chemical pneumonitis, and surfactant inactivation. The obstruction of small peripheral airways acts as a one-way valve, leading to gas trapping and hyperinflation. This severe air trapping can cause alveolar rupture, resulting in complications such as pulmonary interstitial emphysema, pneumothorax, or a large pneumomediastinum, which can elevate and outline the thymus to produce the classic angel's wings sign seen on the second film.
How does meconium aspiration syndrome differ radiographically and clinically from transient tachypnea of the newborn and hyaline membrane disease?
Meconium aspiration syndrome occurs in term or post-term infants, presenting with hyperinflated lungs, coarse, patchy, asymmetric consolidation, and a high risk of air leaks. In contrast, hyaline membrane disease typically occurs in premature infants, showing small lung volumes with a uniform, fine reticulogranular pattern and peripheral air bronchograms. Transient tachypnea of the newborn affects term infants, often post-cesarean, and presents with normal to hyperinflated lung volumes, prominent interstitial lung fluid, pleural fluid, and rapid resolution within 48 hours.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these films with prior chest radiographs to evaluate the progression of the pulmonary opacities. I would suggest checking the placement of the endotracheal and nasogastric tubes on every follow-up film to ensure they remain in satisfactory positions. I would recommend monitoring closely for early signs of air leaks, specifically a pneumothorax or pneumomediastinum. Finally, I would document the findings, coordinate with the neonatologists regarding surfactant therapy or high-frequency ventilation, and communicate any sudden changes in air leak status immediately.